Welcome to this anterior segment video in which you're going to show you a very interesting case. This is a patient who's got something in the anterior chamber. So let's start drawing and see what we have. And here you can see this is an intraocular lens. This is the haptic or the optic of the IOL. And this is the haptic of the IOL. Interesting, the IOL haptic is not C-shaped or J-shaped, but it is something which goes more of an S shape. So this is an anterior chamber intraocular lens which is lying in the anterior chamber, but the other thing is it is decentered superiorly and either temporal or nasally depending on which eye it is. We'll find out later. The other thing which we see is an updrawn pupil which is vertically oval, and there seems to be missing iris in the periphery superiorly. There seems to be a limbal wound over here, and the pupil is sort of area where the normal pupil is, there is sort of fibrosis or folding of the iris over that area. So this is an overview of what we are going to see. Let's see with the slit lamp. The next thing which you're going to see is if the intraocular lens. The other thing which you want to see is there is iridodenesis. When the eye moves, you will see the iris shake, and this is the area where the pupil has been myosed, and the superiorly actually this is an area which is broad, which is a superior iridectomy which is present over there. And this is the area of the limbal wound over here. The next thing which we want to see is the anterior chamber depth. The main cause of visual loss in anterior chamber IOLs is corneal decompensation. Why? Because you want to see if this is the epithelial slit, this is the endothelial slit, and this is the slit on the iris. This is the AC depth. So you want to see is any part of the IOL touching the endothelium or not. Usually when you're lying down or you're in prone position, that IOL in this position, which is a displaced IOL, it will be mobile and it will be rubbing against the endothelium. The other thing is it is also going to rub on the iris as well. So most probably this patient will have low-grade anterior uveitis. They can also get hyphemas, which are part of the UGH syndrome. Now you want to see carefully will a slit beam if there is anything or not. Then you go into the pupillary area to look at the fundus examination, go on a higher magnification, and we see a yellowish sort of a reflex coming in from the pupillary area. To go in with a higher magnification, you see something is moving over in this area, which looks like more of a retinal detachment. And the other thing which you now see are these blood vessels on the surface, which confirms that is actually the retina, and it is the movement of the retina which you are seeing when the patient is moving is the eye. Here you can see this area of the retina, and it shakes when the patient's eye moves. So this is a patient with a pseudophakic anterior chamber IOL, superior iridectomy, myosed or seclusive pupillae, along with a old closed funnel retinal detachment over here, which is seen. So it's an interesting case with multiple findings, but the important thing is you need to identify what we are looking for step by step, and then tell your findings as they are or document them as needed. Thank you very much.